Okay, so moving on. So we talked about disorders of menstrual timing and how they're almost always due to disorders of ovulation, right? If you're not having regular periods, then you are not ovulating on a regular basis. So let's talk about what causes that failure of regular ovulation. So there are three main disorders that we're going to talk about today. So hypothalamic amenorrhea, polycystic ovarian syndrome or PCOS, and premature ovarian failure. Of these three, PCOS is the most common. All right, so we're going to start with hypothalamic amenorrhea. So remember, amenorrhea means absence of periods, although it turns out that a lot of times people actually just have irregular periods with this because they're not ovulating regularly. So they might have an absence of periods or they might have irregular periods. So if I were in charge, I would call it hypothalamic anovulation, meaning lack of ovulation, but I'm not in charge. So it's called hypothalamic amenorrhea, even though they might be having irregular periods. So this happens when the hypothalamus in the brain decides, you know what? I don't think this is a good time to get pregnant. So in these individuals, there won't be GnRH, right? Because the hypothalamus is like, let me hold off. So the pituitary won't make LH and FSH, and therefore the ovaries aren't going to mature the follicles and do all the things we learned about last time. So what would make the hypothalamus think that now is not a really good time to get pregnant? Well, there's really kind of three main categories of things. One is excessive exercise. And what is excessive can vary from person to person. So we see this often in elite athletes or sometimes even in recreational athletes, people who are exercising a lot. Their brain says, gosh, we seem to be fleeing from predators all the time. So I think this is not a good time to get pregnant and have a vulnerable infant. We're not really sure why this evolved this way. But if you're really active with really high levels of exercise, that can cause the hypothalamus to basically shut down the system so that you won't get pregnant. Similarly, and relatedly, if you're extremely underweight or malnourished, or even if you have disordered eating but aren't underweight. So problems with nutrition, so eating disorders, weight loss, malnutrition, whether due to an eating disorder or other conditions, can also cause hypothalamic amenorrhea, which if you think about it, if you're not well nourished, then yeah, it's not a good time to get pregnant. Pregnancy takes a lot of extra calories and a lot of extra nutrients. So if you're very underweight or malnourished, or even if you just have disordered eating, the hypothalamus is going to shut things down so that you don't get pregnant. The final thing is stress. So both mental and physical stress. So if you get really sick with mono, sometimes this will happen, or we often see it sometimes around finals or when people first come to college as freshmen, right? Even when things are emotionally stressful, your body can think, maybe we shouldn't get pregnant right now. So the hypothalamus shuts the system down. No GnRH means pituitary doesn't make LH and FSH means the ovaries just take a nap and go on vacation for a period of time. All right, so this is all of that information on a slide. I want to point out a couple of things kind of at the bottom of this slide. So the problem, you might think, oh, it's really nice not having periods. Like, this is great. I'm totally fine that I have hypothalamic amenorrhea. The problems are here. If you're not if your ovaries are basically on vacation and they're not making estrogen, you don't have enough sex hormone in your bloodstream. And that over time will cause a loss of bone density. So it increases your risk of having osteoporosis, brittle bones. We see that a lot in our eating disorder patients, even if they're exercising a lot, right? So even if they're doing a lot of weight-bearing exercise. Again, as you know, we talked about how anytime you're not having regular periods, the endometrium is disorganized and you're at increased risk of endometrial cancer. So that's another risk. And also in people who have hypothalamic amenorrhea for prolonged periods of time, they are at higher risk of future infertility for reasons that are not entirely clear. But so there are long-term repercussions of having hypothalamic amenorrhea. So the question becomes, how do we treat it? Unfortunately, you have to correct the underlying problem, right? So we have to get rid of the reason why the hypothalamus thinks that it should shut down the reproductive system so that it can restart again. There are other things that we can do to help support the body in the meantime. So we can use birth control pills or progesterone tablets to help protect the endometrium and decrease their risk for endometrial cancer. But that won't at all help their bone density, their risk for osteoporosis, or their future risk of infertility. It doesn't obviate those problems, right? Those problems will still exist even if we put somebody on birth control pills. We used to think birth control pills would fix the problem, and now we have really good evidence that they don't. They just help protect against endometrial cancer, which is important, but not sufficient. So we really need to work on fixing the underlying problem. All right. Number 2. Polycystic ovarian syndrome, or PCOS. So this is really common. Depending on how you define it, it probably affects anywhere between 10 and 30% of female-bodied people. And what we see happening in PCOS, obviously it's named because they found a lot of cysts on the ovaries. And when you look at the ovaries, not everybody with PCOS has a lot of cysts. But what you'll find is a lot of follicles that don't fully mature. And so further research has shown that in people with PCOS, there seems to be an imbalance with LH and FSH. So LH, as you remember, tells the theca cells to start making hormones. You might also remember that they make androgens. And then it is up to FSH stimulating the granulosa cells. Those granulosa cells take those androgens and convert them into estrogen, which helps fully mature the follicle and the oocyte. So what we see in people with PCOS is they actually have high levels of androgens, testosterone-like hormones, so androstenedione and testosterone, these masculinizing type hormones, and they are not ovulating regularly because they seem to have trouble kind of converting it into estrogen. So the symptoms that we see in people who have PCOS is that, one, they're not ovulating regularly because they're not fully maturing their follicles, so they have irregular or absent periods. And then they also have some symptoms related to these excess androgens. So we'll see more acne in people with this condition, predominantly in areas that are kind of androgen responsive areas of the skin. So in people who don't normally have androgens, it's uncommon to get a lot of acne around the jawline, upper back, and the chest. But people with PCOS, because of those high androgens, can get acne in those locations. We'll also see increased hair and hair on the face, right? So you can see kind of some sideburns here, as well as on other parts of the body, right? Because of the actions of these androgens, these testosterone-like hormones, including testosterone. So that's PCOS. It's very common. There are also some metabolic consequences of PCOS that have to do with how the body handles and processes insulin, and they get pretty complicated. And so they're also at slightly higher risk of diabetes and some other things that are kind of beyond the scope of our talk today. So again, it's really common. They have excess androgens. They don't ovulate regularly, so their periods are irregular. And so they have this increased facial and body hair and acne. And so, of course, if you're not ovulating regularly, it's harder to get pregnant, right? So they're more likely to have trouble with infertility. And again, because they're not having regular periods, they have that disorganized endometrium and are at increased risk over time of developing endometrial cancer. So the treatments for PCOS vary. So we can give them hormonal birth control or progesterone to protect that endometrial lining to decrease their risk of endometrial cancer. That will also help them have regular periods, which is just not medically necessary, but might be nice for the person. We'll also give them medicines that are kind of anti-androgenic, so medicines that kind of counteract testosterone and androstenedione. The name of that medicine that we use in this country is called spironolactone to help decrease some of those symptoms of the excess androgens. There are some fertility treatments that we can use to try to help them to ovulate if they want to get pregnant. And in some folks who have PCOS, changing their diet towards foods with what we call lower glycemic index, increasing exercise can be helpful. So in some variants of PCOS, nutritional therapies and exercise are helpful. In some people with PCOS, however, those do not help, so it varies. So that's PCOS. The third and final one is premature ovarian failure. This is basically premature menopause. This is ovaries in a young person deciding, you know what, I've had it, I quit, right? So they're basically entering menopause early. And so you may have heard about hot flashes that occur with menopause. So these people would get that as well. So let's think about what's happening now. If the ovaries are refusing to do their job, then levels of estrogen are going to be low because that's one of the jobs of the ovaries. So the hypothalamus, of course, is going to say, oh my goodness, there's not enough estrogen around. So, of course, then the hypothalamus will make GnRH, and that will cause the pituitary gland to make LH and FSH. And in fact, they're going to try so hard, they're going to basically be yelling at the ovaries, come on, do your job. Then in people who have this, we'll find that their LH and FSH levels are really high, higher than what we typically see because their hypothalamus and pituitary are just trying so hard to get the ovaries to do anything at all. So that's premature ovarian failure. So this is not common in young people, right? Usually menopause doesn't happen until around age 50, but there are some things that can increase your risk. So there's a genetic condition called Turner syndrome, where people, instead of having 2 X chromosomes, only have 1. So you'll remember that you need at least 1 X chromosome to survive as a human, but you only need 1. Like people with XY just have 1 most of the time. But some people have XO, they just have 1 X chromosome and not a Y or not a second X, so that they can have premature ovarian failure. If you've had chemotherapy or radiation therapy for previous cancer, that can damage the ovaries and make them kind of give up early. Some autoimmune diseases can do this. And then there's unknown, which is one of the best words in medicine, which is idiopathic, which means we don't know what causes it. Idio means I don't know. Pathic means the cause of disease. Treatments, so we would give these people hormone replacement. We would give them estrogen tablets and progesterone tablets so that they can not have hot flashes and so that their bones can stay strong. And if they really want to get pregnant, then they would be looking at maybe doing some in vitro. And sometimes it can be successful. So I just want to kind of show you overall the treatments for these problems with ovulation are going to vary depending on what we're dealing with. So remember, for hypothalamic amenorrhea, we have to correct the underlying problem, whatever it is. We can protect their endometrium, right, with hormonal birth control or progesterone, and they don't usually have any symptoms other than the absence of periods. For PCOS, nutritional and exercise therapies can be helpful for some folks. We'll definitely use hormonal therapy to protect their endometrium, and we will also use anti-androgen medicines to help manage their symptoms of excess facial and body hair and acne. In premature ovarian failure, if we're giving them estrogen replacement, then we'll also give them progesterone so that we don't get that imbalance on the endometrium, and we'll use those just to treat their symptoms. All right, so just remember that although giving somebody birth control can often make them have regular periods, if there's somebody with hypothalamic amenorrhea, if we don't correct the underlying problem, they're still at risk of weak bones and future infertility. All right, so this is the summary, right? So hypothalamic amenorrhea, your brain thinks now is not a good time to get pregnant, either because of insufficient nutrition, excessive exercise, or stress, and we have to fix the underlying cause. For PCOS, we get this imbalance between LH and FSH, between the theca and granulosa cells, ending up with an excess of androgens and failure to ovulate. And so we're going to treat that with hormonal therapies and anti-androgen therapies, and sometimes exercise and nutrition therapies can be helpful. Premature ovarian failure, the ovaries just quit and give up and go into early retirement. And so what's interesting there is that their levels of GnRH, LH, and FSH will be high as those parts of the brain try to force the ovaries to at least do something. All right, so that's it for 9C. 9D will be disorders of menstrual symptoms.